Everybody, welcome back to the Dr. Terri Show. I'm here again on the beautiful island of Puerto Rico with some brilliant gynecologists, Dr. Alvarez from the Latin Doctors and Dr. Mallory, and we are going to be going a little deeper again today on hormones and bioidentical hormone replacement versus synthetic hormones. If you've ever wondered why you're depressed, anxious, irritable, can't sleep, can't focus, can't concentrate, have joint pain, plagued with chronic diseases like maybe hypertension, maybe high cholesterol, maybe some sort of metabolic issue like type 2 diabetes, it could be your hormones. So we are going to be talking about all of that today, the impact of hormones on chronic diseases, and dispelling some of the myths and misconceptions around breast cancer, prostate cancer, the Women's Health Initiative trial, which is what got us all confused in the first place. So come on in and join us in the conversation with Dr. Alvarez and Dr. Mallory. It's going to be a lot of fun. All right, Dr. Alvarez, Dr. Mallory, thank you. Welcome. Thank you for taking time out of your busy day, been operating all day, and then you got shows, and you've been doing what you do all day. So thank you. I'm really grateful for you to be here. So we're going to talk about hormones. Obviously, this is what you specialize in, among other things, but we can't talk about it without first talking about how we got here with all of the fear and misconception and misinformation around hormones. So, let's talk about some of the WHI pitfalls. I would love to hear from you, Dr. Alvarez, on that.
WHI is a Women's Health Initiative study, which was started at the beginning of the 1990s. And they had like 40 centers around the United States, and they recruited like around 160,000 patients. Yeah. And they did several things. They did hormone replacement therapy. They did also low-fat diets. They used vitamin C, vitamin D outcomes. Yep. But what we're talking about is about hormones, right? They had these patients, and they concluded in 2002, they published that the use of hormones, estradiol, conjugated estrogens with medroxyprogesterone acetate or estrogens by itself could increase the risk of breast cancer and myocardial infarction, thromboembolism, strokes, Alzheimer's disease, colon cancer.
Right.
Okay. There was several things that were not taken into consideration, not only by the authors, but by the medical community and by the media. The media was one of the most responsible of giving the false information.
Right.
And then
on the cover of Time magazine,
Cover of Time magazine. One day, all of our patients in our office, we were partnered for over 30 years, would go to our office, menopause, here's your prescription. All of a sudden, we had, the phone calls were ringing, all over. Number one, they used a population which average age was 63 years old, or over 13 years after menopause started. Okay,
right.
30% of these patients were hypertensive medications. 50% of the patients were smokers or previous smokers, and 70% of the patients were overweight or morbid obese.
Yes.
And besides that, the myocardial infarctions and strokes happened average at 70 years old. So you cannot extrapolate what happens to a 70-year-old smoker, obese, and hypertensive patient to an early menopause patient at 45 years old, 47 years old, which is essentially healthy. So it's was one of the pitfalls. The other big pitfall is they only use one modality of hormone replacement.
That's right.
Okay, they used conjugated equine estrogens with medroxyprogesterone acetate, which is not a progesterone; it's a progestin. And they concluded that using this combination would apply to any other modalities, which is not true.
Right.
Even that study has been reviewed. The same patient has been followed for 20 years, and the authors have retracted what they said.
Correct.
Even the authors have.
But that wasn't put on Time magazine cover.
That wasn't put on Time magazine.
That doesn't make news.
Okay, they knew that those pitfalls were right, number one. They knew that the combinations of hormones did not necessarily extrapolate to new combinations of hormones, like, for example, estradiol and micronized progesterone. Even though there has been many studies that have tried to reproduce those same results,
absolutely,
and they haven't been able to. On the contrary, they have showed decrease in cardiovascular disease and probably a protection from breast cancer.
And colon cancer.
And colon cancer.
Yeah. Colon cancer.
Okay. Yeah. Decreased patients with low levels of estradiol and testosterone have a lot more risk for developing not just colon cancer, but prostatic cancer.
That's
also.
right, for men.
So for men.
Absolutely. So what I'm hearing is, one of the main things is that the study population wasn't the representative of the average patient that comes into our offices to get reviewed for hormone therapy. What would you add to that?
And at the same time, it's very, very important that people comes not only for hormones, they come for a general evaluation.
Yes.
And then when you realize that patients are having symptoms, because we always talk about these topics with the patients depending on their age, and you realize that they may having symptoms that they do not realize are related to hormonal imbalance, and they feel, as I mentioned to many people, 10 years ago you were hearing the same symptomatology as post-COVID.
Yes.
I have a brain fog,
Yeah.
I have a tiredness,
Right.
And the thing is that you realize that there was something happening, is the decrease in the hormonal levels, but you have to rule out other possible diagnosis as
Right.
hyperthyroidism. Once you do that, you evaluate the patient and then you offer them the possibilities. And the possibilities may include hormone therapy. But when Dr. Alvarez mentioned that the WHI, that was a study that was done with therapies that were not natural.
Correct.
So we have seen the effectiveness of this therapy for the last 10, 15 years, 10 years that we're using natural hormones. But before that, we were giving therapies with a Premarin or
Yes, the
Prempro,
synthetic hormones,
and people
yeah.
were doing fine, except for a very small amount of people.
Well,
that-
really, it was just the progestin arm, right? You know, and so you bring up a good point. I'd love to hear, just explain to our audience, what is high level, the definition between bioidentical and synthetic, because even there's a lot of clinicians that are confused because, ACOG doesn't promote bioidentical, even though Viveldot is bioidentical and Prometrium is bioidentical. So let's clear that up a little bit.
Well, synthetic hormones, the word says is synthetic. For example, conjugated equigen estrogens, the mechanism of action and the way they act in our body is not the same way that bioidentical hormones do. And bioidentical, they're called bioidenticals because they biologically are identical. The way they work in our body, it's like a key getting into a.
Good, yeah.
The receptor accepts the hormone just as if it was a hormone produced by the ovary. So instead of producing inflammation, they are anti-inflammatory. Instead of increasing breast cancer, they might protect you against
Mitigate,
other
right.
diseases, especially bone health. Since we stopped using estrogens in 2002, we've seen in our office an increase in Alzheimer's,
Yeah.
cognitive disorders, depression, divorces, sexual dysfunction, insomnia, patients receiving medication by depression disorder, major depression disorders, hospitalized, patient getting divorced. So
Yeah.
So
That's such a big one.
osteoporosis, the incidence of bone fractures have increased a lot, even though we have a lot of other medications which are directly for treating osteoporosis. And most of these patients don't use those medications. Most of those medications give them a lot of side effects. Most of those medications, you cannot use them for more than 3 or 4 years because
Right.
they can affect your bone architecture. So definitely it's been a pitfall for women.
Absolutely.
That study.
And
Definitely.
Yeah.
something that is not mentioned in all those studies is quality of life.
Quality of
And
life.
quality of life is something that has to be measured because
Absolutely.
many people tell me, hey, listen, I prefer not to live so much, but with a good quality of life.
Absolutely.
I cannot have 7 different type of medications for the different kinds of conditions that I have,
Right.
like hypertension, diabetes, and at the same time, for muscle pains
Absolutely.
and joint
Yeah,
pains,
joint pains.
and at the same time depression, and
Yep.
it's
And it all exacerbates each other, right?
But when people are in this, there are most of the people in which they are going to feel better, and I do not recommend to them discontinue all the other medications,
Right.
but they discuss it with their primary physicians,
Sure.
and they are tapering down the medications that does not need to be used because they are in hormonal balance, which is very important for the people, and the quality of life is completely different.
For sure. And I can't emphasize relationships and quality of life enough, not only with spouses, but children and coworkers and, everybody else. You touched on something important that I'd love to hear from you about, and especially in the Latin community, the chronic diseases that are majority are preventable, right? And so what do you guys see as the impact of hormones on those chronic diseaes in your
Oh,
practice?
definitely, they
Yeah.
improve a lot. You see blood sugars lowering down, insulin resistance lowering down, obesity. One which we manage these patients patients and they get an energy to do exercise, they're starting a good strict diet or with a nutritionist, they start losing weight and losing weight the natural and the healthiest way, not just using, HCG or other modalities, which, you're going to lose weight, but you're not going to lose it like the way you want to lose it, forever, Besides, one other thing, adding up to Dr. Mallory, that I would like to say to the patients, if you have your gynecologist or your primary physician which wants to start you on hormones, and then you have another physician which said, no, don't start those hormones. If you start those hormones, you get another doctor, because I've heard that before.
Yes. Oh, that's so unfortunate.
Yeah. Me as a doctor, what you do to the patient is that you explain the treatment, explain the pros and cons of the treatment, and the patient decides which treatment is going to be she's going to receive. You're not going to impose, you're going to have to use this.
And if you don't, I won't
see. It's her body. She's going to decide for it. So I tell my patients, the cardiologist told me not to use that. If I'm using that, get another cardiologist. I put, get another cardiologist.
Yeah, 100%.
So, because, it's your body. You're the one who's having the problems and the symptoms. So, well, just
absolutely. And, we talked about this before we started, but, there's a great study that shows it takes about 8 to 13 years before the medical community will change a practice even after the data's come out. So now we see the big study from post-WHI came out in 2020 that the even conjugated equine estrogen prevents breast cancer and breast cancer mortality, but it'll be 15 years, 12, 15 years before we see that. What do you think is one of the biggest barriers? I think that a lot of, you've mentioned cardiology, you've mentioned oncology, some of these clinicians that are, don't understand the hormones. Like, what is the best way, I think, for us as clinicians and also patients to manage that? I don't know how.
I think that the best way is the approach of any patient with their particular doctors. When they realize that they're improving in all the fields, orthopedic surgeon, physiatrist, cardiologist, internal medicine,
psychology,
endocrinologist, rheumatologist, and they feel that patients are improving, then they start to hear the patient and they change their mind. And sometimes when they feel that their patients are under a comprehensive evaluation to avoid possibilities of risk associated with the hormones, then they call you. Even when they initially didn't think that it was a good alternative, then they call you and say, can you evaluate this patient for me? So it is a matter of time that they will change their mind. Obviously, with all the studies that are coming, they feel
better about it, right? But they got to get access to the studies. What do you say about that?
Yeah. Another thing is that, many authors have said recently, medical schools and residency training programs, since we graduated, I graduated 32 years ago, there were no hormone training inside the medical.
Still there's none.
Not even the medical school, or not even in the gynecologic residencies. So these doctors go out to the street just remembering what they studied at the exam from the WHI, and that's what they think. So I think we have to start not by, always we have to educate the patients, but we have to start educating the physicians.
Absolutely.
And it starts at the center where you get trained.
Yes.
I think that's a movement that's going on, and many medical residencies are trying to implement a new, just hormone replacement training during that period.
Well, even unfortunately, it's interesting, but, testosterone for women, for example, because there's no FDA approved, all testosterone use is off label for women, in the States at least, and I'm sure in Puerto Rico as well, and maybe that is the reason why it's not really taught in medical schools, because there is no drug for testosterone. Like, what are your thoughts on that? It's a big missing piece.
In our specialty, for example, preterm labor, we used to treat it with Breathin, which is an asthma medication. It's off label for preterm labor. With magnesium sulfate, with an anticonvulsive therapy, which is used for preterm labor, and we are trained with that. We have that on our board examinations, and they're off label. So you have, why can you have something off label and not hormones?
Absolutely.
So I think it's all media and all, it's
and you just need to see the change in the quality of the life when you give them
even the lab biomarkers
and the lab. And another significant problem is that people in the labs and doctors say, hey, the testosterone is higher than expected.
Too high.
This is not a patient, this is a patient which is under treatment, not a patient that comes to you with a very high testosterone, then you have to look for other possibilities. But in a patient that is in treatment and you feel better, they come and they understand when you
Absolutely.
explain to them.
Well, that brings up another good point about testosterone, because I know you use testosterone in all your patients across the age spectrum, right? And across the reproductive spectrum. How do you approach the conversation with your patients of when they get that lab back and maybe their primary says, oh, your testosterone's so high? How do you explain to them that, no, not necessarily?
Well,
How do you explain?
it's a matter of the goal, which is the goal of the therapy, at which level we should go, and up to which level is good, and then we are going to tapering down or tapering up the testosterone in the next round.
But why isn't it symptom relief? Like, when before all this, and a woman came with hot flashes and all the symptoms of menopause, you didn't check her labs, you gave her Premarin, and you didn't check labs to see if we need to lower the Premarin dose or all the things.
Nobody do that.
Nobody does that. So why is this different?
I have started to do
300-pound patient received the same dose as a 125 patient.
Yeah.
And you used to increase the dosage depending on symptom relief.
Correct.
Okay, it's not depending of chronic disease relief or increasing
or
bone
the
mass
lab
density.
levels.
So,
I mean, it's a matter of, again, educating, right? I mean, it is so hard, I think, for a lot of clinicians to grasp that. One of the things that you said before we started, which were really important, talking about mental health of our patients, and my doctoral work was on depression and androgens, so it's very important to me. But how do you had mentioned approaching your patients with anxiety, with depression, and sometimes saying, it might not be the fact that you need this SSRI medication. I want to hear from both of you on it.
The most important thing is you may have several conditions, and hormonal therapy may not be the treatment for each one of them, but being in a well-being balance may improve the way that you feel your disease. Particularly in terms of depression and anxiety, people are doing better. But whenever the hormones start to fade out, then they may feel that they're having depression or anxiety again. And the problem is not in the medication that they are using, is that she is going back to the imbalance of the hormones. So sometimes they need to come, and the family need to be aware of this, and the doctors and the psychologists or the primary physicians that are taking care of them, they need to let the patient know that probably is the hormonal imbalance is coming back, and it will take between 3, 4, 5 months, depending on the amount of exercise people are doing, because the way that they use the hormone therapy depends on the amount of exercise that they are doing.
Yeah.
As a matter of fact, we have a lot of psychologists and psychiatrists which already send us the patients to start an hormone therapy prior to start any medication. Obviously, if you have a 30-year-old female with major depression, you're not thinking about hormones. Or if you have a 78-year-old female that never had depression in her life, you have to think about cancer. Or
For sure.
External factors, not internal factors. So you individualize every patient.
Absolutely.
Patients 40 years old to 55, 57 years old who start with new onset depression. There's no exogenous factors, no divorce, no the death of any relative, loss of the job, bankruptcy, things that can provoke depression. Then you should think about the possibility of hormonal imbalance.
Yeah.
And you always have to deal with psychiatrists or psychologists, because we are not psychologists.
Sure.
And you have to be sure that the patient is taken care of.
It's interesting that you get the referrals from the psychiatric world here. How did that come to be? Did they just get educated over the last decade since you've been doing this? I
think they've seen patients come back in hormones,
doing
and they
better.
say, well, I stopped using my Wellbutrin 3 months ago because I used testosterone, and I'm feeling the best of my life.
Absolutely.
And they keep hearing that and hearing that again, and then I think, well, maybe this works. And some of them, him too, they send us the patients before starting them, unless they have major depressions.
Absolutely,
But even
course.
with major depression, people may feel better.
That's
and
right.
you have to be very careful that if they start to develop symptoms, it's probably a hormonal imbalance instead of needing to increase the doses. And it's very important to have that conversation with the patient. You need time. This is not a matter.
It's not an
go
overnight.
to the room, I give you the pellets, and you go away.
It's not, I have a headache, it's gone, 4 hours after I take the medication. So we can't leave the guys out. you treat men in your practice?
Yeah, we do.
Of course, you would have to. The women
Not as
probably
much as
bring.
women. Or, 10% of our patients
Yeah.
are.
So there's a lot of myths and misconceptions even for men around testosterone. So what are some of the main ones you see that you would like to make sure the men understand in this space?
Yeah, prostatic cancer. The main concern is I'm going to have prostatic cancer.
Right.
The people have told me that if I've used testosterone in high doses, I'm going to get
Man boobs.
man boobs, and all the things. But mostly that the patients that come to our office mostly are because they're married to another patient
Sure.
that is receiving
Except-
hormones.
Now she feels good. She has libido. She has energy.
And
She's
usually
like,
it's tiredness, loss
Yeah.
of concentration, loss of body mass,
Yes,
muscle mass,
muscle mass.
which is very important in guys.
Sure.
Okay. Arthralgias,
Yes.
joint pains, and that's the sexual dysfunction in
Sure.
some guys.
Yeah,
So
sure.
that's the main reason they come to ask for orientation about hormones.
Absolutely. And their happy relationship after they
Definitely.
get that
Of
going
course.
on.
Of
Yeah, for sure.
course.
And so do you see resistance as you're both gynecologists?
Yes.
Yes. Do you see any resistance with treating men here with
No,
your
not
peers?
at all. Some urologists, the old urologists,
school.
they used to treat, they still treat prostatic cancer using Lupron. Because Lupron is a generation analog which blocks the production of
Yeah.
testosterone.
Miserable.
Now, the new urologists, they're trained differently, and they
Yes.
know that prostatic cancer is a low testosterone disease.
Correct.
It doesn't occur in people that 30 years old when they have a 600 level testosterone.
100%.
It occurs in patients, that are older when they have a low testosterone. And many studies have showed that patients with, and over 19 studies have showed that patients with low testosterone disease that are treated with hormone replacement, testosterone replacement therapy improve a lot, and they don't increase their risk of developing prostatic carcinoma.
Correct.
Even patients that undergo prostatic surgery for prostatic carcinoma, if they're not metastasized, everywhere,
Yep.
but usually those guys that go surgeries because they're not metastasized.
Right.
Otherwise, they're going to go with radiation therapy or hormonal therapy and chemotherapy, right? But those patients, once they get operated, if usually I have a urologist, oncologist here, which is one of the most famous here in Puerto Rico, and he sends me over the patients after
Nice.
he operates them. Once the PSA remains low,
Yeah.
0. Then after 1 year of surgery, they let them undergo testosterone replacement therapy, and it's a life changer.
That's
Definitely.
totally a life changer. I mean, I have had men that have come to me, left their urologist on Casodex and Lupron, and said, I would rather die of prostate cancer than stay on that drug. So give me my hormones back, And so it's good that you have a progressive urologist that's, thinking outside the box.
And very important is whenever you are dealing with a condition in which there is another physician involved in the
Absolute.
management, to have a very good relation with
Yes.
and a conversation
Yes.
with that doctor, because it is better for the benefit of the patient that
100%.
both you are working in the same
Yeah,
team.
100%. Yeah,
The
that's
same
good.
team,
One thing we haven't touched on that people are always confused about, are hormones something that's just for 50 and over? So what's too old, what's too young? I want both of you to answer it.
Well,
Go
it
ahead.
depends. Gynecologically wise, we have a lot of premenopausal patients, premature menopause before 40 years old, 30 years
Yeah.
old, premature ovarian failure before 30 years old, genetic conditions, radiation therapies, surgical patients, patients that are undergoing several treatments, medications that can produce, block their hormones. Those patients come to your office. I have
Absolutely.
a lot of 28, 26-year-old females in hormone replacement therapy due to premature ovarian failure or Rokitansky syndromes where they don't are not born with uterus. Sometimes the ovaries they don't work as long as they should. Right? So there's different diagnoses that make younger females lose their hormones. So that's
Yes.
when we start the treatment.
What about how old's too old
Too old
not
for
old.
hormones? That's right. I love that.
But I can say you what is too old for a man. A
What is-
cardiologist sent me a person for hormonal treatment. He said this person is perfectly well.
Yes.
Yeah, but
So age is just a number.
I need you to write to me that he needs hormones.
I have a couple
He needs
names.
hormones. He needs
Yes.
hormones. Pellets, pellets.
Yes.
90-year-old.
100%. I mean,
So-
I have 80s, 90s also, and that's so good to hear. You have a couple of older guys in the
I have
days.
a lot of 90 years old,
Yes.
a lot of 80-year-old females. So between 70, I would say the most age real I have in my office, I would say would be from 60 to 75. So, you know.
Yeah, that's the average.
Yeah.
Average age.
Another thing is even Alzheimer, even
Yes.
in early stages, there may make a difference for that patient and for the family. But I'm not saying that that's the treatment for Alzheimer.
Correct.
It's just to give another.
Although in
alternative.
early stages, we are seeing some data that's showing reversal in some of the damage, which is really interesting. What do you want to say about the brain and hormones? I want to hear from both of you because we've talked about a little bit about the heart. One thing we didn't mention is the inverse relationship between testosterone and heart disease. So lower the testosterone, the higher the heart disease risk. Same thing with estrogen in the brain. But what do you say about the brain?
Definitely. Testosterone, for example, aromatizes in a little bit of estrogen, and at the neurocellular level, that aromatization has been proven to improve neurodegenerative disorders. So testosterone improves cognitive disorders, cognitive failure, and Alzheimer's disease, such as estrogen.
Yes.
So definitely,
testosterone men, estrogen in women. And the heart, of course, protects in many of the same ways, anti-inflammatory, immunomodulator.
Endothelial wellness, decreasing LDL. Testosterone increases in HDL.
Yes.
So now the combination, you have one of the hormones being anti-inflammatory inside the blood vessels. It prevents them to get stiff and rigid.
Yes.
So it prevents hypertension. It prevents arteriosclerosis, and it prevents strokes because we don't
Absolutely.
have endothelial inflammation, which is probably one of the most common causes of strokes. Instead of other. If it was a bleeding stroke.
We got to get away from thinking it's all about cholesterol and this and that, because although that matters to a degree, a lot of it is, it's all inflammation, which has many, many root causes. Before we wrap up, if there's just one more thing we haven't talked about that you really want people to know about, I want to hear that from both of you.
What?
Anything we haven't talked about related to hormones that you want to make sure the audience gets.
If you think you need hormones, just go to a physician which is certified,
trained.
Ask them for the pros and cons.
Yes.
You have to get a lot of information, see who's going to recommend you the hormones, why he's recommending the hormones. He's going to give you the pros and cons, possible side effects. What happens to those side effects? Can I treat those side effects? Are they permanent? Are they transitory? So you have to get well educated before you get into any type of treatment, not just hormones,
Yes.
But as always, you have to follow the wave. Thank God we're going back to 20 years ago where hormones are getting kicked again. We're getting a kick in a use of estrogens. So don't be afraid. Just go to a certified doctor. He'll know if you qualify for the hormones or if you're not a candidate.
Absolutely.
Not everyone is a candidate for hormones.
Absolutely.
Most people are.
Most people are.
Most
Anything
people
to
are.
add to that, Dr. Mallory?
I need to add something that many people are worried about breast cancer related to estrogen. No matter how many studies comes, they still feel because have the
it's been ingrained in our brain.
But I can say something to you. People who are under hormonal treatment are well evaluated in terms of breast cancer than people who are not using hormones. So people that are not using hormones and they do not have a mammography in 5 or 6 years, when they come and you identify that there is a breast cancer, probably it's in advanced stage.
That's right.
If you are coming on a yearly basis, following the rules for mammography, and you have any lesion identified, then you have an over 90% chances of cure, even if it is cancer.
Yes.
So it is not necessarily related only to the benefit of the hormones. It's related to the benefit that you have when you are under close surveillance by a physician.
That's good. So don't wait too long.
No.
Yeah, it's never too late. I can't thank you enough, Dr. Alvarez, Dr. Mallory. You guys are amazing. And we'll have all your information on how to find you if any of the audience wants to become a patient in the information about the show with your bio and your websites and everything. I appreciate your time.
It was
Thanks
a real
for coming.
pleasure. Thank you
Yes,
very much.
thank you.
My pleasure.